All right, so we're going to go ahead and get started because we don't want Jeff coming down on us, telling us to hurry up. So my name is David Lee. I am the practice supervisor at Rimrock, and this is Kimmie Miller. She is my injectable nurse at Rimrock. There is one typo on the presentation of implementing acting injectables in the primary care setting. Kimberly Miller is now HIV/AIDS certified. Her and I are both a handful of nurses here in the Coachella Valley that are certified. So it's a congratulations, Kimmie, on that.
Thank you.
So it's going to be just a little intimate group here. If you have questions, just raise your hand at any time and I'll be sure to answer those. All right, so neither one of us have any financial information to disclose. Implementing long-acting injectables for HIV can be challenging, but is absolutely possible. It has gotten so much easier in the past couple years. When we first started, it was not fun. First thing we want to do is make sure everybody is trained. So training and education of healthcare providers. Primary care providers may need additional training on the administration of long-acting injectables, managing the side effects, and monitoring patients. Education on patient selection criteria, injection schedules, and interactions with other medications is also required. Pretty straightforward. If they're a primary care provider, they just are going to have more training, especially if they are not HIV certified and so forth. But it absolutely can be done. Kimmie? So this is a very important slide.
Storage of your medications is obviously important. We need to make sure that the Cabenuva is refrigerated and not frozen. The other two, the Apretude and the Sunlenca, can be at room temperature. Obviously, your room still needs to be at an appropriate temperature under 77 degrees. We suggest that you have a medication refrigerator also or a thermometer so that you can keep track of those temperatures, because once you receive the medication, it's your responsibility. So it's a pretty expensive thing to mess up.
Absolutely. And the reason I say this is because we've had that issue where our refrigerators have gone out of temperature and we've lost Cabenuva. Once Cabenuva reaches a certain temperature, it is no longer sustainable for use. And we want to make sure we're giving a good product to make sure it's nice and safe for those patients. All right, patient adherence and scheduling. Patients must adhere to regular injection schedules. And in other words, there is a Cabenuva that is monthly. There's also Cabenuva that's every 2 months. We have one patient that receives it monthly, so you have to make sure that he's scheduled. They're scheduled every month, and then everybody else is every 2 months for Cabenuva 2 months and Apretude. Sunlenca, as you learned from Dr. Gauthier this morning, every 6 months. So you just got to be sure that those schedules work for that patient before starting the regimen. It can be logistically difficult, like I just said, especially for those with limited access to healthcare or transportation. We don't really think about this too much being here in Southern California, transportation, but it can be, for people that have a lower income or don't have cars, getting to the doctor's office every 2 months can be quite difficult. Missed appointments could result in reduced efficacy and the potential for developing drug resistance. It's very, very important. You heard Dr. Gauthier mention this morning with Apretude. You don't have your lab work done for Apretude, you don't get your medication. Why? Because we don't want to, in case you do have HIV, we don't want to cause a resistance to that medication. It's not just that one medication. It can be a whole class of medications that you may lose. So we have a philosophy is no labs, no injection, just because we want to keep that patient safe. Smooth coordination with pharmacies must be ensured to avoid any supply chain delays affecting scheduled doses. This is the biggest issue that we can say with implementing Cabenuva into any kind of setting, is working with those pharmacies, working with the insurance companies to make sure we have that medication in stock every 2 months. One thing that we have done, Kimmie's whole entire position, is to make sure this happens. Right now, we have about 150 patients, and it takes her every bit of her day to coordinate with the pharmacy and insurance company, making sure we have those prior authorizations and scheduled deliveries. So it's if you are someone that is thinking about implementing this into your practice, it takes probably an additional person or an additional couple hours out of your day to make sure you can do that. Cost and reimbursement. Oh my gosh, this has gotten so much better. I can't tell you how much better it's gotten. More insurance companies are paying for the medication. The only challenges we have here in California are if you have out of state insurance, the biggest one being out of Texas for some reason. We found that those insurance companies are a little more challenging. We have to jump through some more hoops. But most of the time, Kimmie can get it approved within a couple days, if not a couple hours. The biggest obstacle also is out-of-pocket expenses for that patient. It's hard to explain and get them to realize that, yes, this is going to be more expensive out of your pocket initially in the very beginning. At that 1 year mark, we found out that it's actually less expensive than oral medications. But the issue is going to be, does that patient have enough money in the first initial couple months to pay for that medication? There are several programs out there. The drug companies do have copay assistance cards that can help them with that, and that most everyone we can will qualify for that unless they're on Medicare. If you're on any kind of government program, you cannot get assistance through a copay card. There are some grants companies and so forth that can help with that. One of the terms that you'll probably also see is a white bag versus a brown bag. So what is that? I did not know what this was. A white bag is basically you're using that specialty pharmacy, CVS specialty, community, Walgreens, and so forth to get that medication. It makes our life so much easier when we can have it white bagged. Brown bag is what's called a buy and bill. So basically Eisenhower Health is buying that medication. We are administering that medication to that patient and then billing the insurance company afterwards. So you are taking a little bit of a risk if you don't have that prior authorization and so forth in effect, because that insurance company can come back and say, we're not going to pay it. So you may be out $6,000 or so.
Right. Some patients may prefer to take pills over the injectables because they're afraid of needles, which happens a lot. They're afraid of the pain or just getting injections in general. We just need to make sure that we're educating them. Our providers are pretty good about that, answering all their questions before they ever come to see me, but still it's your nurse's responsibility to reiterate those and answer any further questions that they have. The biggest feedback is injection site pain. What I found is if you inject the medication slowly, it helps with their pain after the fact. So don't just jam it in there. It's a lot of fluid. It's 3 milliliters on each side. So if you inject it slowly, their pain after the fact is a lot less. See, high acceptance among patients due to preference around stigma because they don't have any bottles to take anywhere. They come see us, they get their medication. Nobody has to know but us. Also fewer doses. Like we said, it's 1 month apart for the initiation dose and then every 2 months after that. So they don't really have to think about it other than coming to see us every 2 months after their initial doses. And they can travel, they can do whatever they want in life and don't have to worry about taking those bottles with them when they see people. And also you should make sure unless they refuse, which does happen, have them lay down, obviously on your exam tables or whatever you have in your rooms, have them lay flat. They can completely relax that way. A lot of people will tell you, oh, I can stand, it's fine. I get my testosterone that way. I get my whatever that way. It's actually better. They have less pain if they're laying flat. They can relax, just talk about whatever, give them their shots and then let them go about their day. And their pain is actually less in the days that follow.
So I'm going to add on to that real quick. One of the things I think is so great is that flexibility to travel. Cabenuva and Apretude, they do have a window period of plus or minus 7 days. So if somebody knows they're going to be gone in 3 months, but that happens to fall on their injection day, well, you just scoot that up a little more 7 days each month beforehand or 7 days later. So that way, when they're traveling, they don't have to worry about taking medications or so forth. And it's just great. I can't tell you how many people I've heard come in and say that it's changed their life. So this is just something that is awesome. So managing side effects and drug interactions, as the provider, you still need to monitor for side effects or potential drug interactions. I can say they're very limited. I mean, because it's bypassing the GI tract, it's next to none from what we've seen. You still want to do that vigilance. We need clear protocols for managing adverse reactions or treatment failures. That's why it's very important to get that lab work, because we want to make sure that they're still staying virally suppressed. Also, you want to be able to assure what happens if you give them the first dose and a reaction happens while they're in office. You want to be able to manage that. So you want to have Benadryl, diphenhydramine injectables on hand or so forth. But the main thing we see is the injection site reaction, pain, like Kimmie already said. You want to be able to sure that they can sit there for 15, 20 minutes at least, have ice, heat, be able to relax them or so forth. I haven't seen yet, knock on wood, where we've had to do beyond that. Most people tolerate it very, very well. I think in my few years of doing this, I've only seen 2 people, less than a handful of people not want to take it anymore. I wanted to add this slide in there just because I think social determinants of health is a very important thing to discuss. We want to ensure that all the patients, especially those in rural or underserved communities, have access to long-acting injectables. It's a challenge, but it can be done. So that's why we want to present this, getting it out to primary care clinics and showing you how you can do it. It's a challenge, but we are standing proof that you can do it. And you just want to address any disparities in healthcare infrastructure and access to regular follow-up visits is essential. So that goes back to transportation, being sure that they're able to come to their appointments and so forth. So these challenges underscore the importance of strategic planning, comprehensive provider training, patient-focused education, and a robust systemic support to effectively implement long-acting HIV injectables in a primary care setting. That was quick and easy for all of us.
All right. Good afternoon, everybody. So a lot of this has already been discussed, so I'll be breezing through it, particularly all the prep stuff, the injectable stuff. So I'll just be summarizing it, and then the latter part of my talk will be on doxycycline post-exposure prophylaxis. I'll go a little bit more in detail about that. So PrEP has been around for quite a long time. It has really revolutionized how we see HIV. It's, as we all know, HIV is no longer considered a death sentence, but we have to realize that, like, outside of the metropolitan areas, HIV is really still a huge challenge. 87% of people don't know it. A lot of people, especially minorities, are at greater risk. And we kind of get blindsided because, I'm a PrEP specialist and all my friends are on PrEP, and we kind of take it for granted. But as soon as you step outside these gay centers, you go to Riverside, you go, to other areas where access isn't so prevalent, you still have a lot of people who engage in high-risk homosexual behaviors, and they're not on PrEP, or they think nobody knows, and they don't get regular checkups. And those are the ones that harbor HIV, and a lot of people don't know. So here's some statistics about HIV. Of course, it affects minorities, and that has a lot to do with access to healthcare, and a lot of it also, what they talked about earlier, that stigma that comes along with it, taking a pill every day. Let's move on to PrEP. So currently there are 3 forms, possibly 4. The oldest one, of course, is Truvada, has been around for a very long time. That's what a lot of people are on already. The newer version of Truvada is Descovy. It's kidney friendlier, and now there's Apretude. The big difference is cost and kidney toxicity. Most of my patients do pretty well on Truvada as long as they're not chronically dehydrated. But if you're chronically dehydrated and you're on Truvada and you take anti-inflammatories, that just can really hit a hammer on your kidneys. Descovy, you have a lot more leeway. It's less toxic to the kidneys. So when my patients, if I see there's a 20% drop in their kidney function, or if I see that they're borderline, I can usually make a case to put them on Descovy instead. So this will be a little bit over the breakout. Again, we'll go over this since a lot of the people this morning have talked about it. The minimum GFR or filtration rate for Truvada is 60, but again, if they're borderline, I'll just put them on Descovy instead. For Descovy, the minimum GFR is 30. Most of my patients are on it. If they end up dropping even further, that's when I recommend them over to Dr. Galtier's office for the injectable. Something that has happened as of late, we do have a lot of Medicare patients, older patients have chronic kidney problems, have to be on Descovy. And whenever that change would occur, I would have to go through this whole spiel about how my Medicare patients would have to find other ways of getting Descovy. But as of 3 months ago, PrEP medications are no longer considered part of Medicare D. So therefore, before when it was Medicare D, Descovy may be covered or maybe not. Even if it was covered, it would have a huge copay. So it wasn't feasible for a lot of our patients. Some of my patients even used international pharmacies because it was still more cost effective. But as of around 3 months ago, Medicare B, the medical benefits covers PrEP medications, including Truvada, Descovy, and Apretude at no cost to the patient. So that's been a big game changer in that patients no longer have to go outside my clinic to look for their PrEP care. They can stay with me, which they seem to prefer. So that's been a big change. But one of my patients brought up a good point, how long is that going to last? With the new administration, they may make some changes, so we'll just have to wait and see. So PrEP is taken daily. That's how it becomes effective. There is such a thing as PrEP on demand, which we do not recommend. A lot of countries where access and cost is a care, they do recommend taking PrEP. It's better than nothing, but not here in the United States. And I do have some patients that insist upon it because they only play around every once in a while, but it's not something we recommend. So it is extremely effective against preventing HIV. Non-scientific poll, Dr. De Rosario has been an HIV specialist for several decades. I've only been with his practice for about 3 or 4 years, but we actually had 2 people seroconvert to HIV in the last 3 years since I've been there. So of course it happened when I was there, but in the last 10 years, those were the only 2. And those 2, there was one PrEP patient who ran out of insurance. He was trying to make his PrEP last longer, which of course he's seroconverted. And the other one was an older gentleman who swore he only ever did oral and had wanted to start barebacking. So then, of course, we did his PrEP labs and he was HIV positive. I'm like, are you sure you haven't barebacked? And he's like, no, I'm sure I haven't. So again, it's no longer a death sentence, but it really points out how effective HIV treatments are for undetectable patients and for the PrEP patients that we've only had those 2 people in our clinic become positive. Something else that has made a huge difference is what we'll talk about next. So I have been told that out of all of Eisenhower, I do the most STD testing. So whether that's good or bad, it depends on your point of view. So before June of 2023, I would average anywhere between 20 to 30 positive STD cases, meaning chlamydia, gonorrhea, syphilis. And right around that time, and I'm sorry, I said I was going to fast forward through a lot of the PrEP stuff since a lot of the specialists talked about it early this morning. So PrEP protects you against HIV, but not against STD. So we started prescribing what is known as doxypep. So there are a lot of different iterations on doxypep. There's doxycycline pre-exposure, there's doxycycline post-exposure. The way that we are recommending and that I've seen high success in is that we're recommended as post-exposure prophylaxis. So basically what it comes down to is this is not something you take every day. Here are some statistics that I'm sure we're all familiar with of the most common STDs. But what it comes down to is you have a 24 to 72-hour period after possible condomless sex. So I make that very clear with my patients because somehow they still equate it with barebacking. It's like, well, all we did was, play with each other, suck this, suck that. I'm like, well, did you take it? Like, well, no. Well, can you get syphilis, chlamydia, gonorrhea while doing said action? And if that's yes, then that's condomless sex. It's not barebacking, it's condomless sex. So you really want to teach those patients that, I tell my patients, anytime you play outside your relationship, you always want to take your doxypep because, I've had patients that were, you know, they're like, oh, I didn't think I needed to take it. I was playing with one of my regulars. Like, well, you're in your regular exclusive. And they're like, well, no. I'm like, well, I'm sure he's having sex with other people, and that's why you got chlamydia now. So let me get to the official one. So a single dose of 200 milligrams taken 24, 72 hours after condomless sex, 88% reduction in chlamydia, 88 or 87 of syphilis. Very, very effective against those two. And I always say about a 50-50 on gonorrhea. So again, non-scientific poll, used to get 20 to 30 positive cases per month. I started prescribing doxypep, and in the last year and a half, now I average maybe 2 to 5 positive cases a month. So it's made a huge, huge difference in positivity cases. It's also made a huge difference in complications from those cases. I still have gotten a couple of syphilis cases. I remember last December, there were 2 positive cases, and they both told me that they swore they took their doxypep appropriately, but they fell in that 13%. It can still happen, and it's not 100% proof, but I've been pretty happy with it. You still want to get screened every 3 months. One key thing that I try to hammer home is that there have been no resistances shown when taking doxypep. One of the things patients talk about, we talk about antibiotic stewardship, the responsible use of antibiotics and resistance to multiple drug resistant organisms, but we have not seen any studies shown where chlamydia, syphilis, or gonorrhea have become resistant to doxy. The one thing I do worry about, if my patient is taking doxy and they come in for any other infection, okay, well, I have an upper respiratory infection. Well, then have you been taking a doxypep? If I am considering doxy for that patient, I have to take it off the table. So doxy is good for complicated upper respiratory infections, but particularly good for skin infections. So I have not run into that problem too much as of yet. The only 2 exceptions, I've had a couple of patients where they got an abscess or a skin infection and they were allergic to, sulfa or penicillin. So I couldn't put them on Bactrim. I couldn't put them on that. And because they had taken doxypep, that's one less thing that I could put them on. So sometimes you have to think outside the box, but I have not seen any resistance to STDs, and I have not seen a spike in, I know there was I think there was an antibiotic resistance gonorrhea that was going around that I heard some people at the AP got, but I never saw that in my office, which, could be good or bad. So as far as everything else, do you guys have any questions specifically about either PrEP or doxypep?
Doxypep is the screen against all STIs?
Yes. Yes, because it protects against, HPV is the most common STD, but out of the ones that we treat directly, syphilis, chlamydia, and gonorrhea. For all our patients and all PrEP patients, we screen for syphilis every 3 months, no matter what. In case you guys are not aware, syphilis has 2 to 3 month delay in positivity. So we never test for syphilis, we treat it. So if somebody comes in, oh, I was exposed to syphilis, we don't test them for syphilis because it's likely going to be negative. So I always read about this in school, but it's actually happened to some of my patients where, it's one of my PrEP patients, and I always tell them, okay, you're HIV negative, your syphilis is negative, and your kidney function's fine. Yeah, well, what about this? And he whips it out, and there's a big sore. And the first thing I do is, did that hurt? They're like, no. I'm like, well, that's syphilis. Yeah, but my test is negative. I'm like, you have primary syphilis. There's a 2 month delay in positivity, and we need to treat you accordingly. So that's classic example. I had another one that he had bit his tongue. So I was looking at his tongue and I could see where he bit it, but right behind it, he had this really nasty, uglier sore. And I poked it with my tongue blade. And he's like, no, well, he's like, he couldn't feel. I'm like, well, you have syphilis in your mouth. Like, how can that be? And I'm like, well, that's classic primary syphilis, a painless sore that looks like it should hurt a lot, but it doesn't. And then one point that I didn't bring up for my highly sexual patients, which I have a lot of, we don't want you taking doxycycline every day. We don't want you taking it every other day. The most we want you to take it is every 3 days, and that's if you're highly sexually active, because the guideline is 200 milligram dose, which is 2 pills within a 24 72-hour period. So you have a 3-day window. So through what I've seen in my clinic, I've had patients like, well, Christian, I played on Friday, so I took it Saturday, which is appropriate. But then I played on Sunday again. Do I take it again? And the way that we prescribe is post-exposure, so technically you would have to. But I'm like, if you know there's a possibility you're going to be playing in 3 days, just give yourself those 3 days, and on Sunday take the pills. And again, I've been prescribing it for a little over a year and a half. And the guidelines differ as far as what to do in these situations. But what I've had success with, my patients who go on extended play vacations where they have a lot of sex continuously, whether every day or every other day, I had them take doxycycline every 3 days. You still want to get them tested as soon as they come back, but I had one that went to Lazy Bear for 10 days, one that went to Berlin for 2 weeks, and he's like, Christian, I've never had more sex in my life. I know I got something, but I test them and they all came back with nothing on them. And to be fair, I don't think it's because my patients are on doxypep. I think by now its general use is pretty accepted, and a lot of other people are on doxypep as well. So it's just keeping STD rates down overall. But so far, I've been very happy with it because there's just a lot less complications that way. It's not necessarily a risk. With doxycycline, you want to be careful about photosensitivity. You want to be careful about alcohol intake, but for me, it comes down to the basic medical belief that you want to take the minimum effective dose that's effective. So just taking a pill every day, if you took doxycycline every day, yeah, that would work the same thing. I have plenty of patients that are on rosacea, doxy every day for rosacea, and they don't get any STDs. But if you don't need to take it every day, if every 3 days serves the same purpose, let's keep that medication input to a minimal and keep the side effects to a minimal, but yet still get the benefits. Yeah, and something I forgot to mention, the official guideline is 2 pills. I always call it the end of the fun weekend dose. Like, you play Friday, Saturday, Sunday night, you take 2 with dinner. Taking it with food, you want to avoid antacids, calcium, multivitamins. People usually take that in the mornings, but taking it with food is less likely to upset your stomach. I do have some patients that have very, very sensitive stomachs, and instead they take 1 pill with dinner, and they just have to remember to take the other one with breakfast in the morning. When we were prescribing this, that's how I first prescribed it, 1 and 1, and both methods seem to work well. So you seem to have some leeway, but the general official guideline is take those 2 pills as 1 pill, take that dose as 1 pill, take that 200 milligrams at once. That way, in case people forget that second dose and it's subtherapeutic and it's less likely to work. But both methods seem to work pretty well, because I have a couple of patients that just are very sensitive to it, and that's what they're doing, and they still come back negative. Of course, any other questions? All right, well, thank you for having me.